Hello, I'm JP Haas. I'm one of the musculoskeletal radiologists at University of Nebraska Medical Center. This is MSK MRI 101, Protocols, Reading Patterns, and Reports, focused on the knee. The outline is going to be the following. We're going to discuss a little bit about MRI basic protocols and uses. I'm going to discuss reporting, which is freehand versus template reporting, two different approaches to reading MRIs. It basically comes down to personal preference, which one you use. Both are fine. We're going to use a pattern-based reading approach, which is predominantly going to be a checklist approach. I'll show you what checklist document I use when I read MRI of the knee, and I will try to make that document available to you as needed, because I think it's very helpful to have in front of you if you are going to start reading cases. The goal of this is basically just to have a high-yield basic approach to reading cases. At the end of this, I will put a scrollable study that you can go through on your own if you have access to the PowerPoint, which I will try to give you access to if you would like, so you can practice and go over the anatomy and look at a normal case. Here's our basic knee MRI protocol. This is our shortest study that we have at our institution. It's only 4 sequences. It's our main workhorse protocol that consists of 3 planes of axial, sagittal, and coronal PD fat-sat, and a sagittal T1 weighted sequence without fat-sat. It has a broad use for routine knee pain, internal derangement, fractures. Other protocols that we have in our institution are the following. They're less commonly used, but most importantly address metallic artifact. We have a post-op protocol and a total knee protocol. They're fairly similar to another, but have a little bit of different uses that are listed there. I'm not going to spend too much time on these because it's not really in the spirit of learning the basics of knee MRI. Here's an example of template reporting. This was found on RSNA Red Report, which is a great resource for all kinds of shell reporting. This is a very good one. I have gone through many of these and found that some of them I like better than others, but this one is very nicely categorized into all the things that we would look at on a knee MRI: meniscus, ligaments, extensor mechanism, fluid, osseous and articular structures. I think it compartmentalizes pretty well and is very efficient. We don't use this at our institution, but there would be no good reason not to. Most of the faculty at our institution tend to use freehand reporting, so they'll just make their findings and have their reading approach and use that dictation. We do have PowerScribe shells that are available to you, though. This is one that is available if you look at any of the musculoskeletal faculty's PowerPoint shells, and this would be another good way to have a good starting point of what to dictate on a knee MRI. Here's the reading pattern document. It's a fairly extensive sheet of things to look at. It's subdivided into the sections of ligaments, menisci, articular cartilage, and then I have other, which it comes down to how I approach things and look at a sagittal view to look at the extensor mechanism, and then go on my axials to do an around the world checklist of where I'm going around the knee to look at various structures. And then finally I finish up with the bones. This is a busy slide, but basically what I'm going to do is snip out the little sections that we're going to look at individually, and we'll go over both some normal anatomy and pathology to look at this further. Finally, we're getting into some actual images. This is the ACL. This is the first structure that I'll look at in my normal reading pattern approach. The ACL has 2 bundles, the anterior medial and posterior lateral bundle. And if I'm thinking about going down into the intercondylar notch and starting high, it basically starts a little bit more laterally, and then as I dive down inferiorly, it goes more medially. This is better shown in pictures, so I'm going to show that on a couple of different planes here. The first one I think is going to be a sagittal plane. So I'm coming across sagittally on the knee. I think I'm starting medially. And what I'm looking for once I get into the intercondylar notch is this nice, straight, taut, dark structure and the intercondylar notch, which goes from superior to inferior in that orientation. That is a normal looking ACL. Now as I go through further, and I'll finally get to the other sequence here, which is an axial. This is coming from low to high. And I mentioned here that it goes from superior lateral to inferior medial. So if I'm coming from down below, I'm going to be starting to look a little bit more medially here and try to find my ACL, which I think is going to be right about here. And as I come up, I'm going to follow that structure up, and I'm going to kind of bracket it the best I can. And we keep on following it up and up and up, and finally it attaches here at the lateral aspect of the intercondylar notch. So that is 2 runs through the normal ACL. An ACL full thickness tear can have many different appearances. Here's a couple examples of what they can be. If the ligament is not seen at all or exploded, that is a good look for a complete full thickness ACL tear. Laxity of fibers with complete discontinuity, focal disruption in the ligament, or empty attachment sites. Here's an example of a full thickness ACL tear just taken from the literature. You can see some torn ligament here, but it does not appear to have any good attachment or discernible fibers proximally, which is going to be a full thickness ACL tear. ACL partial thickness tears can be a little bit more tricky. This can involve disruption of either the anterior, medial, or posterolateral band, but that is often hard to decide which one is which or where the tear exactly is. The partial tears, at least, are known to be usually from the anterior medial band. But what you want to make for a key finding is you have an abnormal ligament, but you still visualize at least some degree of intact contiguous ACL fibers. So what can the abnormality be? It might be angulated or lax fibers, intrasubstance tears, or an overall small size on the chronic timeline. So here's a couple examples of this. Often the history is helpful. You know there was an injury and you're looking at the ACL, really looking for tears very carefully, and you think it's there, but either it's edematous and a little bit thickened, or it has some other abnormality but does have still intact fibers. One other finding that is a related concept as far as having increased T2 signal in the ACL is mucoid degeneration. This should not be going along with the history of trauma, but does have similar findings. In the ACL, there is increased T2 signal and thickening. Typically has a very preserved striated pattern. It can be one of the best findings to help you know what you're looking at. That celery stalk look of the ACL is preserved, but it's just very thick and very bright. Typically not in the absence of trauma and is usually not clinically significant. One finding that can be associated is a ganglion cyst next door, which is an example here. And that is usually also not clinically important. ACL can have ganglion cysts. These can be within the ACL or separate from the ACL. They can be clinically significant if they cause any mass effect on adjacent structures. And these are best just described on how they look, where they are, when you report on them. The PCL is the next door neighbor in the intercondylar notch to the ACL. If you're thinking about the intercondylar notch and starting up high, will start a little bit more superior medially and then more progress towards that midline in the posterior tibia. This ligament is usually not torn in isolation, and it also is normally shown as a continuous band of low signal. It does have normal size criteria. If you do measure it on a sagittal image, it should be 6 millimeters or less in size. So if it is thicker than that or has increased signal, it might be an indication that there is a history of tear. Showing some examples of that on the imaging here, we're going to show, I think, our same images here are sagittal, PD fat sat weighted sequence starting medially and then coming across the knee. This time we're going to look here at this structure that is in this orientation at the posterior aspect of the intercondylar notch, and that is a normal looking PCL. Show you that here on the axial. Starting low to high again. So since we know I said it starts kind of in the midline posterior aspect of the intercondylar notch, that's going to be our PCL right there. And we can follow it slice by slice as we go up the intercondylar notch before it attaches a little bit more medially in the intercondylar notch. That is a normal PCL. PCL buckling is usually not a very important finding, but something that can be just described in the report. It can be an associated feature of ACL tear where it just has a more curved morphology than typical. And that is where I would leave the finding if you see it. You could say buckling of the PCL, but that's probably all about you need to say. PCL partial thickness tears. PCL tears can be partial or complete. They have similar criteria to ACL injury, where you look for ligamentous laxity, edema, or partial or complete disruption, like you see here. This is a slice where I can't tell you on this one slice if it's full thickness torn or not, but if there is more of it coming in here, that could be part of a partial tear. And the partial tear is shown by this thickened T2 hyperintense ligament. The other thing that I have found is that you can call a PCL tear just based on that size criteria that I was talking about. This comes from an AJ article, that if it is more than 6 millimeters in thickness, it is it is basically analogous to a functional tear. So you can keep that in mind when you interpret the PCL. Here's an example of a PCL full thickness tear. This is a ligament that we're just not seeing very well. It looks like there's some torn irregular fibers more proximally, and distally the PCL is not seen at all. So this would be a good look for a PCL full thickness tear. Next, I go to the MCL. The MCL has two components. There's a superficial and a deep. The superficial is the long, more superficial ligament that goes all the way across the medial knee, and the deep has what I call the meniscotibial and meniscofemoral ligaments, which are the deep components. And between those two, there is a named bursa, which is called the MCL bursa. So I'll show you how that looks. I'm going to show you on a coronal image here, and this is the patella, so we know we're coming from anterior to posterior. We want to make sure we know medial from lateral. This is the iliotibial band over here, so that's a nice landmark for lateral, so that makes me know that we're going to be looking at the other side of the knee. And here is the MCL starting to come into view here. So it starts up here on the medial femoral condyle. The superficial MCL is quite long. It runs all the way across the knee and inserts down towards the tibial metaphysis. And I'm showing you on 2 or 3 images here this nice long normal look of the MCL, superficial. The deep MCL is right next door. I can't go back and forth here, so I hope I haven't missed them that, but they are just named for where they are. The meniscotibial ligament, which was about here, and the meniscofemoral ligament, which is here. So those are the deeper structures of the MCL that you want to try to find. And we have a little bit of different focus here, but you can kind of see those coming in here. And they usually are pretty well seen, so I would just encourage you to look at those on your own and make sure you're trying to find the deep MCL when you're going through the case. MCL thickening is a descriptive finding. It could be a variant anatomy or indicate an old MCL injury, but if it just strikes you that, especially if there's a segmental area of the MCL that is thicker than the rest, it can be mentioned in the findings. MCL sprain is described as follows. There's 3 different grades that are available, and the first one is periligamentous edema with otherwise normal ligament. So basically the MCL looks fine, just has edema around the ligament, and that is a grade 1 sprain. A grade 2 sprain is when you have the periligamentous edema, and then you also have an abnormal but not completely disrupted ligament. So as you follow the superficial MCL down, you'll notice that here it gets thick, there's T2 hyperintense signal, it's not normal, and then as you follow it down, it kind of still comes back and is there. So this is a nice look for a grade 2 MCL sprain. It looks like there's some disruption of the meniscotibial ligament here as well, whereas I can see more normal looking meniscofemoral ligament along the deep aspect there. An MCL grade 3 sprain implies that there's full thickness disruption or a completely disrupted ligament. Here's an example here at the medial knee where you have this lax ligament where the proximal attachment is kind of hanging off in the breeze and not attaching normally to its femoral condyle, consistent with full thickness tear. That's on a coronal sequence. If you looked at it on an axial, it might look something like this, where you have complete disruption and absence of the normal attachment site of the MCL. The lateral collateral ligament, or LCL, has 2 main components, the fibular collateral ligament and the biceps femoris. They join together near the fibular head to become what's called the conjoint tendon, and you can assess that on a sagittal imaging if you can find that Y shape, which is a nice thing to look for. I'm not going to show the sagittal imaging here, but if you do practice on your own, I would suggest trying to look at those sagittal images and seeing if you can see how those 2 components come together to form what kind of looks like a Y. So what I'm going to show here is our coronal images, again coming from anterior to posterior. Now we're going to be looking at the lateral side of the knee. And what we're going to be looking for first is we're going to have our attention here at this lateral femoral condyle, and we're going to try to find where this LCL starts. And this is the fibular collateral ligament. And I should erase that a little bit so you can see it a little bit better. You'll notice that there is a little bit of signal here on the picture. And I find that this is kind of a normal look. It doesn't really hold up on if you correlate it with an axial image, but this is still kind of a normal look of that fibular collateral ligament. And you can follow it down here, and it will eventually go down to the fibular head. The other structure that I have my line right over here is the biceps femoris. That's the other part that we want to look at. right here, and that is one of the hamstrings tendons that comes down here to forms the conjoint tendon. So that's one run through the coronal images of what the lateral collateral ligament looks like. When reporting LCL sprains or tears, it's best just to be descriptive about the location of the tears and whether those tears are partial or full thickness. They can involve either the fibular collateral ligament or the biceps femoris or the conjoint tendon. This one looks like kind of just a mess everywhere, but we clearly have a complete disruption down here in the area of the conjoint tendon where there's a fluid gap consistent with a full thickness LCL tear. There's an associated finding that is typically more of an X-ray finding, but you can see fractures on MRI as well, what's called an arcuate fracture, where you have an avulsion injury of the fibular head, and that relates to where that conjoint tendon inserts. The posterolateral corner is a fairly complex area of anatomy that has both major and minor stabilizing structures. I highly suggest to focus on the first three, which I have labeled here in blue, which are the major structures of the posterolateral corner. One we've already talked about, which is the lateral collateral ligament, consisted of the fibular collateral ligament and biceps femoris. The second is the popliteus, and the third is the popliteofibular ligament. So I think this is good to know. If you get asked a question that, oh, what are the most important structures of the posterolateral corner, I would try to memorize these and be able to kind of describe where they go and what they are. The more minor structures of the posterolateral corner are the fibellofibular ligament, the arcuate ligament, and the posterior joint capsule. And one thing that I remember being taught from when I was learning is that if the major structures are normal, then very likely the minor structures are normal. So that's why we can more focus on these major structures to basically think we have a good evaluation of the posterolateral corner. So let's try to find some structures of the posterolateral corner. Same coronal image here coming from anterior to posterior. We already showed the LCL. So what we're going to be looking for especially is the popliteus and popliteofibular ligament. The popliteofibular ligament is important, but I don't think it's well seen on every single case. It's good to know where it is to try to make sure you could see an abnormality if it was there. So let's keep going here. We still haven't quite come into the LCL. And what we're looking for the popliteus is this kind of diagonally shaped tendon which comes across the knee here, and you're going to notice it kind of in this orientation as you come across the posterior aspect of the knee. It'd be very nice to be able to go back and forth to look at this better and see it all as you come to view, but you will see a muscle come here. Now the popliteofibular ligament is a ligament that shoots off the popliteus and goes to the fibular head, and it's typically just deep to these geniculate vessels, which I think are what you can see right here, but at least at trying to see where this should be, this is the area you're going to be looking. So let's go a couple more slices and see if we can get anything more here, and we're already kind of coming out of it, except to show you that this is the popliteus coming in. So best to look at that on just practice, go back and forth and try to do it on your own. This is how the popliteus and popliteofibular ligament should look. This is nicely shown in schematic here on the posterolateral corner. So I showed that biceps femoris and lateral collateral ligament coming down to the fibular head, and then the popliteus coming up here through what's called the popliteohiatus to its attachment site. And then you have this last important structure here, which is this asterisk structure coming off the tendon and inserting on the most medial aspect actually of the fibular head. And this kind of shows that as well. I thought this was helpful. This is more complex anatomy than I would focus on, but seeing where the lateral collateral ligament inserts, where the popliteofibular ligament inserts, you can kind of envision where it should be on the fibular head if you're going through an MRI. And then once again, just showing these blue structures labeled. These are the major important structures of the posterior lateral corner. The popliteus itself, if it's injured, is typically a myotendinous injury. For myotendinous injuries, we can grade those as strains, partial tears, or complete tears. You can have avulsion injuries from that popliteohiatus, which is kind of in this location. Here's an example of a myotendinous junction, grade 2 strain with insertional tears, partial tears of the popliteus and the fibular collateral ligament. So just showing some of those findings here, you have this edema and partial disruption centered at the myotendinous junction of the popliteus. But not only that, you have some irregularities and abnormalities of the insertional popliteus on the more deep part and the fibular collateral ligament, or LCL, more superficially, to represent all those things being partially torn, basically. Here's a popliteofibular ligament. Again, this is a major stabilizer of the posterolateral corner. The best shot is going to be your coronal, to use your coronals and sagittals and look just deep and inferior to those lateral genicular vessels. Here's an example of a normal one, which we'll see nicely. Here's this popliteus, which I'll just bracket here. And as you follow this up and across, you can find this very small ligament coming through and to insert on the fibular head. So down here you have a finding more representative of popliteofibular ligament sprain, where you have a thickened edematous ligament that looks something like this. The meniscus is the next big topic. Here's some examples of what normal meniscus looks like. You have a larger medial meniscus and a smaller lateral meniscus. Has a triangle morphology on imaging, which I'll show shortly. But here's some examples of where the free edge would be as opposed to where the thicker body would be. And here's another picture of what that looks like. They have root attachments, both anterior and posterior horn root attachments, and then kind of designated at the asterisk where the corresponding cruciate ligament inserts. So we'll go through some normal anatomy about how these look on MRI images. So what we're going to show here first is a sagittal. Coming from medial to lateral, we've already started to come into the body of the medial meniscus. It should have about two images where before you get to the bow ties, where you have kind of a biconcave appearance. And then once you get off, you will have your triangles. They should be nice dark black triangles with normal morphology. And you try to follow both the anterior and the posterior root all the way to their root attachments, and they should attach normally like that. Now we're going to come out of the intercondylar notch, and we're going to pick up the anterior and posterior horn root attachments of the lateral meniscus. And here they are here, and we've already come a little bit out into the one here of the lateral meniscus posterior horn. And again, nice dark black triangles as we come across the meniscus before we get to the outer aspect, where we'll again have two or maybe three images of that biconcave disc appearance. So that's a couple, that's one run through what is a normal medial and lateral meniscus on sagittal imaging. And then we can do that on a coronal as well. Coronal, you're going to see that both the menisci at the same time. So if you're trying to find those coming from anterior to posterior, we have already started to come into the anterior root attachments here, maybe not quite on that lateral side. And here it is on the lateral side. Before you see the bodies of the meniscus here, should be nice dark black triangles. Just follow them through until you get to your posterior horn root attachments and your posterior horns. Here's the posterior horns. Now these are C-shaped structures, so you might have to go back centrally to look at these a little better, but you do get some sense of how these insert also at their posterior horn root attachments just based on this one run through as well. The other relevant anatomy to know about for meniscus are shown here. These can be pitfalls into not saying that there's a tear there when there's really just a normal anatomic structure. Up here, I'm showing the transverse ligament, which is a normal structure which can go from anterior horn lateral to anterior horn medial. So you don't want to call that a tear, as that starts off from its origin. Here's the meniscofemoral ligaments. They go from the posterior horn of the lateral meniscus to the medial femoral condyle. They can be located both in front of or behind the PCL. So this is called the Humphrey, and this is called the Risberg, which starts with a W. I just remember that they go in alphabetical order, with the Humphrey being more in front and the Risberg being behind. Down here, we're showing the popliteomeniscal fascicles. These kind of have more complex names, but for simplicity, I think you could just call this the superior popliteomeniscal fascicle and the inferior popliteomeniscal fascicle. This is a structure at the posterior aspect of the lateral meniscus only for this anatomy. And I think that's all I'll say about that. This is a nice image from Radiopedia, just showing all the different morphologies of tear that are possible. The two main words to think about are vertical and horizontal, and we'll subdivide that into how we talk about the tears more specifically. But if you think of just a tear that goes horizontally, like this one or this one, that's going to be your horizontal tears, horizontal cleavage tears, horizontal tear of the meniscus, versus your vertical tears, which are going to go more in the long axis of the meniscus to be a longitudinal, vertical, longitudinal tear. This is a radial tear. That will also appear as a vertical line on MRI image, and I'll show you what that looks like. This is what's called a peripeak tear. It's kind of an obliquely oriented tear that starts on the radial aspect and then makes a turn into more longitudinal. Here's some meniscal free edge fraying. Here's some complex tear. So just many different morphologies of tear that are all nicely shown on one schematic image. And here's a labeled version of that you could look at. The bucket handle is shown down here. Fairly common. You can have an injury that results in a flap tear. So it's a vertical longitudinal tear where there's a flap which flips to, can be different places, but often medially into the intercondylar notch and give what's called the double PCL sign. So now talking more about the horizontal tear. Basically the tear by definition should be parallel to the tibial articular surface. To be a tear, the most important criteria is that it should approximate the meniscus surface, either inferiorly or superiorly, or the free edge on two contiguous images. And this is often the typical degenerative tear, meniscal tear that's seen in older patients. So here's an example of what that would look like. This is a posterior horn, anterior horn body of the medial meniscus. And this is just a drawing of what it might be, where you have this horizontal tear, which cuts the meniscus into superior and inferior portions, or it can go along to near the free edge here. And this is how it looks, how it would look if you were looking at a schematic image. Now, once we actually correlate it to MRIs, it looks like this. This was a nice article that from Radiographics, where you could get a feel for what meniscus tears look like. So basically there is a sagittal and coronal rated representations of where the tears are, and then it shows you on the picture where the tear is. So on this patient, there's a medial meniscus tear which involves the body to anterior horn mostly, maybe a little bit towards the body posterior horn junction. And they show you some cut lines through. So this number 1 line is a sagittal cut through the medial knee. On the number 2 line is a more central cut through the knee, and then on coronal you'll see how these tears would look. But you see how it has the basically horizontal shape when you look at it. So here's number 1. So you start where the tear starts, you'll just see a horizontal line that is in the meniscus. And as long as you can follow it on contiguous images and get it to a meniscus surface, as is shown here on the second image where it touches the surface somewhere out here in the anterior horn, that means it is a true meniscus tear. And then if you cut those in the other perpendicular direction on a coronal, it would look something like this, where you have the signal either approximating the free edge or the surface of the meniscus for where it is actually torn. This is just showing a small perimeniscal cyst, which can be an associated finding with meniscus tears. Here's some real-world examples of meniscus tears. This horizontal, hyperintense signal with a small perimeniscal cyst that, if you scrolled on sequential images, touches either the superior or inferior aspect of the meniscal surface and is a meniscus tear. The vertical tear, first we're going to talk about a vertical longitudinal tear, has a different orientation. It is parallel to the long axis of the meniscus and basically divides the meniscus into central and peripheral halves like this. So you can imagine the tear is cutting the meniscus into central and peripheral portions, and here going from anterior horn body to posterior horn throughout basically the circumferential. This is a more typical tear seen in younger patients with trauma. It is important to say exactly where these tears are. If it's in the peripheral 1/3 of the meniscus, there can be a higher association with ACL tears. So let's show some of these on imaging as well. This is another representation of what this would look like. Here is our vertical longitudinal tear, which is coming around basically the entire meniscus here, and depending on where you're cutting it on the sagittal and coronal images, you can see how the tear would look. If you look here, it cuts the anterior horn and posterior horn, and you'll see that vertical signal touching the meniscus surface at where you can see it cutting through the meniscus. Similar look on both of these. And then on the coronal, same thing. It's a vertical signal that touches the meniscus and looks like that. The axial imaging can be helpful. I started using this more, and I think it can be very helpful, but if you can find one axial image where you find that tear having that vertical longitudinal orientation, it can be very helpful to know what you're looking at. Here's some examples of what a vertical longitudinal tear would look like. I think it's best shown at the body of the medial meniscus here, where you see this more vertically oriented signal. This is actually the peripheralmost part of the meniscus body, so this is all meniscus tear here, and kind of showing once again an axial image where that tear is right there. Vertical tear radial is another orientation of tear. You'll notice that is not in the vertical longitudinal. It's actually across, and it involves what is the key point, the free edge of the meniscus. So this tear transects the collagen bundles along the short axis and also has a vertical linear appearance. It violates the hoop strength and is what the most common tear would be to lead to meniscus extrusion, which you can see typically, especially on coronal imaging. But remember that it involves the free edge. That would be the most helpful. If you think about where a radial tear is on here, it can be in different locations, and it'll look differently depending on where you cut it. So this is a radial tear of the meniscus body. This is the a vertical tear of either the anterior or posterior horn of the meniscus. So if you cut through a tear, you might see a cleft. So that was similar to what we saw, at least for portions of that vertical longitudinal tear. But you often have to cross-reference this. So you had one that looked like a cleft, but then on 4, it looks like a truncated meniscus because you're basically losing a portion of the meniscus here. So you just have to kind of put the two slices together and understand that it's actually a vertical radial tear. You can also have what's called the ghost meniscus. So if you can find the slice where you cut through the vertical radial tear perfectly, you basically won't see any meniscus at all. So that can be a helpful sign to know that there is a vertical radial tear. Here's some examples of that. This is a pretty common one. Seem to see it fairly frequently, where you can see the tear right here, and it is in that orientation involving the free edge, vertical signal involving the free edge, and then it violates the hoop strength, so maybe this body, the medial meniscus, will tend to be more displaced peripherally with respect to the medial margins of the medial femorocondyle and medial tibial plateau. Also often happens at the posterior horn, sort of near the root attachment. It's a very good place to look for these. Here's some comparisons of what the vertical tears are, radial versus longitudinal, a concept that I think can be a little bit confusing at the beginning, but there's one more slide just showing where they look and how they appear. Basically, the main idea is to decide if the tear is along the long axis or short axis, the meniscus, as you scroll through, and keeping that important concept that no matter how you slice it, these radial tears have to go to the free edge, whereas the longitudinal tears typically or should not involve the free edge. Just another example of a root radial tear. This is basically almost the same type of case that I showed previously. Leads to peripheral extrusion and can give you what's called that ghost meniscus sign depending on where you're imaging. Complex tears just have either many different orientations of tear, or the morphology of the meniscus is completely wrong. So I tend to pull this trigger when the meniscus just kind of looks like a mess and I can't really make anything normal. I'll say complex tear. This is a nice example here where you do see many different orientations of tear and would be a very good case to say complex tear and just describe out exactly what you're seeing. Bucket handle or flap tears is when a piece of meniscal tissue flips into an abnormal place. Here's several different examples here. Medial meniscus can flip posteriorly near the PCL. There can be flaps involving the meniscofemoral or meniscotibial recess of the medial of the body of the medial meniscus. Flaps can go into the intercondylar notch. You can have detached free meniscal fragments. And it's very important to describe all these because the surgeons will definitely want to know about this preoperatively. Here's an example here of what is a flap tear, which was flipped centrally into the intercondylar notch. Here's another. This is all meniscus here, but it's flipped superiorly. It looks like into the meniscofemoral recess at the medial knee. This became calcified over time and had that appearance on X-ray. Some more examples of bucket handle or flap tears. Now these are different cases here. At least A and B is a lateral meniscus bucket handle, which is flipped centrally. So you always have to scroll on these, and especially I would say on both the coronal and sagittal images, really to just appreciate how The donor site comes from this place, and you can see how it's flipped to where it's flipped, and then you can reunite it coming back across as you go through your images. But this was a medially displaced bucket handle. We did not have the double PCL sign. Here's an example of what a double PCL sign might look like, where you have a PCL sort of looking thing right in front of the real PCL. Here's where a meniscus flipped anteriorly. So this is the anterior horn. This is the posterior horn, which is abnormal place. You would never call this a normal meniscus just because it does not have that expected triangular shape. Meniscal fraying is a concept that is difficult to show on MRI, or maybe impossible to show on MRI, but can have surgical correlates where you might just have some very subtle irregular signal approximating the surface of a meniscus, but really needs a surgical correlate to see what that looks like, and I think would be difficult to call consistently in real time. Next is the articular cartilage. This goes by the modified outer bridge classification on a surgical basis. So what we try to do is kind of have an MRI correlate for what the differences are, but basically just to emphasize some of the important points of the cartilage classification, it goes from 1 to 4 and shows you here what the description is and what the arthroscopic finding is. Some that I'd like to emphasize are grade 2, just think about it as fragmentation and fissuring. Grade 3, crab meat. I think that's a very descriptive appearance to know what that looks like, but it is near full thickness, loss of cartilage. And then grade 4 is just full thickness cartilage destruction with subchondral bone. So if you're going to try to correlate this with MRI findings, I found this helpful. Grade 1 should just be increased signal, but no loss in the thickness of the cartilage itself. And then once you get into grade 2 or 3, I would just think about it as less than 50% cartilage loss or greater than 50% cartilage loss. And if you can put your decide if it's one of those two things, I think you're good saying grade 2 or grade 3. And if you see full thickness loss with exposed bone, that can be an MRI finding as well, and we can call that grade 4. So here's some examples on images. This is our normal case, and I'm going to focus on the patellofemoral compartment, especially because that's what's best seen on the axial images. But here you just see this nice, normal, fairly T2 hyperintense cartilage on the trochlea and on the patella. So this is beautiful, normal cartilage, and you would call this normal. This was one of the only abnormal findings on this case. There was a little bit of fat pad edema in the prefemoral fat pad. Showing you some abnormalities. So emphasizing grade 1 is normal thickness, but there may be some PD or T2 hyperintensity looking like this. And this is a soft finding. I think if you saw this, maybe you wouldn't say anything, and that would be fine. But if you think there is some hyperintensity there, that would be grade 1 or the most mild form of chondromalacia. Next is grade 2, where you have this descriptive words can be something like mild thinning or mild to moderate thinning or less than 50% chondral loss. Here's the picture. You just see it's less than 50% of the cartilage thickness, and you have this irregularity and fissuring here. And this might be an example of what you'd see on a real MRI in the patellar cartilage to call it grade 2 chondromalacia. Grade 3 is words like moderate thinning, moderate to severe thinning, greater than 50% cartilage loss. Here's an example of a fairly high-grade fissure. And here we have some maybe cartilage holding on at the deep margin, but really and definitely greater than 50% segmental chondral loss with some high-grade fissuring over here, even a little bit of subchondral bone change here. But the best descriptor overall for this would be grade 3 chondromalacia. Grade 4 chondromalacia is severe thinning with full thickness loss or full thickness chondral defects, and especially with subchondral edema. So that should basically, by definition, go to the bone. And you can see here we have some full thickness fissuring and loss, and then more extensive subchondral edema for grade 4 chondromalacia. Now, just to wrap up the cartilage discussion, I think it's a little bit subjective at how you call it on MRI. Maybe depends on your referrers about how they like this called. Some people will say mild, moderate, and severe, and that's okay if you don't actually use that grade 1, 2, 3, and 4 system. Next is the extensor mechanism. I'll be on my sagittal imaging here. Typically, when I'm done looking at my cartilage evaluation, it'll give me a chance to look at my quadriceps and my patellar tendon. I'll show that here. Patellar tendon is what's called jumper's knee if you have a proximal patellar tendinosis. But find your patella and look for your quadriceps coming down to attach on the superior patella. Follow that across to your patellar tendon, and as that goes down to the tibial tuberosity. This is the same as other things, how you talk about tendinosis, partial tear, and full thickness tear. Basically just looking for increased T2 signal, thickening of the tendon, which can go on to either partial disruption or full thickness disruption, depending on the severity of the injury. It's good to follow this on sagittal and correlate it with your axial images. Here's some examples of abnormalities in the extensor mechanism: a full thickness quadriceps tear, and then some fairly high-grade looking patellar tendinosis with maybe some partial tear along the deep margin. That would be a good look for jumper's knee. And then one of the last things I'm doing when I'm doing my normal MRI evaluation is kind of an around-the-world look at the axial. And this is a little busy discussion down here, but I'll look at the medial patellofemoral ligament. I'll come around the posterior medial knee to look at the pes anserine tendons, which are sartorius, gracilis, and semitendinosus. I'll look for the popliteal cyst, and I'll show you what the borders of that are. I'll look at the neurovascular structures, the iliotibial tract as you get more laterally to Gertie's tubercle. And I think it's just a nice approach to be able to look at all those other things that you didn't look, that cruciate, collateral, meniscus, posterolateral corner. It just covers kind of everything else, at least for my reading pattern. So this is going to be hard to show on all one run, but I'll try to do the best I can. We're already seeing some pes anserine tendons here. So I'll maybe just pick a slice and try to show you as much as I can, maybe like here. So I usually start here at the anterior knee and look at this medial structure here. Medial retinaculum, medial patellofemoral ligament is the more kind of ligamentous deep part of that. It's an important stabilizer of the patellofemoral compartment. And then I'll come around here to find my sartorius, gracilis, and semitendinosus. Those are my pes anserine tendons. I'll come around further to look at my popliteal cyst, which should be between my medial head gastrocnemius and the semimembranosus tendon, the two M's, and often there's fluid in between those two. Keep going posteriorly. This is the neurovascular bundle. We've already kind of shot off, it looks like, the common peroneal nerve, but the sciatic nerve subdivides into the tibial nerve and common peroneal nerve, so you can follow that anatomy as it goes around. And the gastrocnemius muscles we already kind of passed through. And as you get even further out here, you can cross-reference this with coronal, but you're going to have your... Here's a little more discussion on the medial patellofemoral ligament, which is a major stabilizer of the patellofemoral ligament. This is probably a little bit too complex for the purposes of an introductory discussion, but I did want to just at least show how it would kind of look on a gross anatomy specimen. There's actually a couple different attachments at the medial femoral condyle. But really just looking for this nice structure here, which should be nice dark black and attaching to the medial femoral condyle. And here's an example of what a medial patellofemoral ligament tear looks like. Here's the pes anserine tendons, or goose's neck. It's the sartorius, the gracilis, and the semitendinosus. I tried to remember, for whatever reason in my mind it stuck S, G, and T. Trying to remember what those are, but they go right down here in that orientation. There is a bursa deep to these tendons called the pes anserine bursa. So if you see a little fluid collection deep to those tendons, you can call it that kind of bursitis. The popliteal cyst is a very common fluid containing structure, which is located between the medial head gastrocnemius and the semimembranosus. Again, here's the sciatic nerve, which subdivides into the tibial nerve and common peroneal nerve. It's very uncommon, but it is quite symptomatic if it is there, if there is an intramural cyst along the course of that common peroneal nerve. So that would be a reason to look at that structure. The iliotibial tract, here's a nice image showing it on coronal. There is this entity called iliotibial band friction syndrome, where you get friction between the iliotibial band and the adjacent lateral femoral condyle, so you get edema between those two structures. It's a little bit of a tricky area because this is near the lateral suprapatellar bursa, or basically the lateral knee joint space. So you really have to make sure that your abnormality is really focused on this area to call it iliotibial band friction syndrome. And finally, one of the last things I'll do is just run the soft tissues again, looking for any other soft tissue masses, periarticular cysts, bursae. I mentioned a few bursae throughout this presentation. There are some other bursa to know about in the knee as well. Basically just, I think, learned experientially as you go through the cases. For instance, the prepatellar bursa is a fluid collection in front of the patella. I mean, usually they are named for where they are and makes sense. So here's some examples of what MCL bursitis might look like, what a semimembranosus bursitis look like if there's a little comma-shaped fluid structure really enveloped just over that semimembranosus tendon. This might be a ganglion cyst or a bursa, similar location at the medial knee there, and here's a prepatellar bursitis here. Other things to look at in the knee joint would be effusion. That's a very common finding that we always will comment on. Synovitis, anytime there's dirty thickening or fluid in the joint space, you can call that synovitis. This is an example of what's called a gradient image, of where you can see blooming artifact that is associated with pigmented bilionodular synovitis, where it basically gets darker and larger on this sequence. And can be helpful in that diagnosis. If there's any articular bodies in the knee, you should look for those and describe where those are. Masses, this is a broad category. I would recommend just doing one more run through the bones just to make sure you don't miss a mass or any other finding in the bone marrow itself. Here's an example of a cartilage-based mass, which is an enchondroma, a geographic, well-circumscribed lesion with chondroid features. Avascular necrosis has a very typical appearance. It has a serpiginous linear signal with double line sign, where there's a low signal rim and a high signal inner surface. An Ant Mini look, just something to know about. It's not commonly seen around the knee, but other findings that would be possible to see on your bones. It's very important to be careful to look for subtle fractures in the bones. Look at the subchondral surfaces for hypointense linear signal that might look something like this, because these stress fractures can be very subtle. The edema always helps, though. You can look for the edema on the fluid sensitive sequence, and it will help you zero you into where the abnormality is. Bone contusions, or where you have marrow edema without fracture, should be with the history of trauma, and there are multiple mechanisms of injury that will give you kissing contusion. So, for example, if you have contusions in the lateral femoral condyle and the posterior lateral tibial plateau, as in this case, that would be a common setup for an associated ACL tear, and you can describe those bone contusions like that. Another good example is the lateral patellar dislocation, where you'll have contusions in the medial patella and the lateral femoral condyle. Bone marrow is important to look at on your T1 and T2 weighted images. Make sure there's no confluent marrow abnormality that could be seen in things like leukemia, hemosiderosis, other lymphoproliferative disorders. This T1 weighted image just shows leukemia where the bone marrow is overall much too dark. Here's a hemosiderosis, which is a myeloproliferative disorder where the bone marrow signal is also abnormal on T1 weighted images. It's heterogeneous and too dark as well. The last thing that we have here is our scrollable images, so I'm just going to quickly go through what those are that you can go through on your own if you want when you look at the PowerPoint. This is the sagittal T1 weighted image. I didn't show too much of this, but it's a very nice anatomic image just to look at your gross anatomy. Here's the sagittal PD fat saturated sequence coming across the knee. The axial PD fat saturated sequence. And finally, the coronal PD fat saturated sequence. So hopefully that's been a good introduction to the MRI just to get you started, and good luck.